My name is Esther Rodriguez. I am a clinical consultant with RMTAC. I will be your host today. I'm excited to welcome you all to the first session of this learning community. A little background on me: I'm a master's level clinician with experience working with regulations in a variety of settings, including human rights organizations, community-based mental health agencies, domestic violence shelters, and juvenile justice facilities. Later on in this session, you'll learn more about my experience with workplace stress and how I was able to identify it. So we'll take a look at our agenda, and as you'll see when it pops up on the screen, we have a robust session plan today. We're going to begin with an icebreaker, followed by introductions and an overview of the learning objectives. We will then hear from our subject matter expert, who will address job stress, anxiety, and depression in mental health professionals. We will then move into a collaborative breakout session. The subject matter expert will then return to provide insights from lived experiences before we close out the session. So I'm excited to introduce our esteemed subject matter expert who we will be learning from through this session. Dr. Irma Perez is a clinical psychologist with experience assessing, evaluating, and treating clients from diverse backgrounds of various age groups, with expertise in trauma, ADHD, behavioral disorders, anxiety, autism spectrum disorder, and intellectual disabilities. We're grateful for her involvement in this learning community and her commitment to the communities we serve. We're also joined by Diana and Sonia from the Learning and Development team at RMTAC, and they will be our producers today. That means they're going to be working behind the scenes to make sure everything runs smoothly. If you encounter any technical difficulties throughout this session, please feel free to reach out to either of them via chat. Their names and roles will appear on their videos. Thank you to both of them. Now, I would love to know where you are all joining us from, so please share your location in the chat. I'll go first. I'm joining from Austin, Texas this afternoon. And if for whatever reason you didn't get a chance to register for this learning community before joining today, please share your name and email in the chat as well, and that way we can email you the follow-up materials afterward. So let me take a look at the chat as people start putting in where they're joining us from. We have Portland, Oregon, West Point, Virginia, Minnesota, Dallas, Chicago, Illinois, Atlanta, Georgia, Santa Fe, New Mexico, Brownsville, Texas, Liberal, Kansas, Houston, Texas, Atlanta, Arizona, South Texas, Phoenix, Fargo, North Dakota, lots of different places, San Antonio, Northern Virginia, Philadelphia, Lincoln, lots of people from all over the country, and we appreciate you all joining in. You can continue to sound off in the chat there. And I'm going to go ahead and move us on to our next section here. So I want to get us a little more comfortable with each other and get a few laughs in before we start with the learning community with our icebreaker activity. So I would like you all to finish this prompt in the chat. Tell me you're a behavioral health provider when, and I've added a few memes to the presentation to get us started, but you can feel free to sound off in the chat as you think of any. So we have a few silly examples here. On the left, it says me after session Googling phrases and words my teen client used. And it says, what does no cap mean? If you've worked with adolescents or youth, they have a lot of funny slang that I don't understand a lot of the time. So I've definitely been that person. And then on the right, it says a teen client says, high key finessed them when I got pressed, no cap. And then it's me looking like a grandma, not understanding anything that they're saying. And we have a couple more. On the left, we have the therapist. Self-care is important. It can help manage stress levels. Also the therapist, overbooked sessions, behind on notes, and on her fourth cup of coffee. We are really good at encouraging people to do better, but having a hard time doing better ourselves. You can see the therapist has like raccoon eyes and insane hair, just exhausted. And then on the right, it says uses aggressive language, chronically lies, and continues attempts to divert conversation. But my progress note says client is skilled in utilizing creative strategies to get their needs met. It's all about the reframe. Um, I see a couple of shares in the chat as well. Um, some people are really enjoying the format. You can read my body language faster than text messages. That's a great one. When you're on your fourth cup of coffee before noon, absolutely. When you start saying things like, let's unpack that, I'm guilty of using that with friends and family as well. I'm sure many of you are too. When you keep plenty of chocolate in the top drawer of your desk, it's the little things that help us get through the day. Thank you all. To those who participated, you can feel free to continue to sound off in the chat, but we're going to go ahead and move forward with our subject matter expert. So during today's session, we are going to collaborate with Dr. Irma Perez to learn how behavioral health professionals working with refugees and migrants can distinguish between vicarious trauma, secondary traumatic stress, burnout, PTSD, and compassion fatigue. As I mentioned earlier, this learning community is intended to be engaging and collaborative. So you're highly encouraged to take advantage of the knowledgeable individuals in the session by being an active participant. And I want to provide some context and background on this topic before I officially hand it over to Dr. Irma Perez by starting with understanding the differences between vicarious trauma, secondary traumatic stress, burnout, PTSD, and compassion fatigue, because they each affect well-being in unique ways and require different approaches to adequately respond. Secondary traumatic stress involves immediate stress responses from hearing about another person's trauma and can often present similarly to PTSD. However, PTSD is a clinical diagnosis, as I'm sure we all know, and it comes from direct personal exposure to a traumatic event. Vicarious trauma develops gradually, and it can also deeply alter a provider's worldview or their sense of safety. Compassion fatigue is the emotional exhaustion from caring for those who are suffering, often combining symptoms of secondary traumatic stress and burnout. While burnout, on the other hand, stems from chronic workplace stress and results in emotional exhaustion, cynicism, and reduced effectiveness. Behavioral health providers working with refugee and migrant clients often face exposure to traumatic material as a result of cultivating spaces for healing and growth for a particularly disempowered population during the tumultuous time of resettlement. I want everyone to understand that in our lines of work, the development of vicarious trauma, secondary traumatic stress, burnout, PTSD, and compassion fatigue is a hazard of the job, and as such should be accounted for in the development of supportive programs for providers and the individual self-care and work-life balance routine. I want to assure you all that these are normal responses to abnormal situations, so acknowledging the symptomatology and proactively addressing them can combat the effects that they have on our functioning. And we're excited to share the information we're about to present, and as we believe that it will be informative and valuable. I think you've all heard enough from me, so I will turn it over to Dr. Irma Perez, who will be presenting the findings from her dissertation titled Job Stress, Anxiety, and Depression in Mental Health Professionals, an examination of experienced vicarious trauma and gender differences. During her presentation, there will be interactive slides in which you can scan a QR code. It might be helpful to have your phone handy in preparation for that. You'll also have the option of opening a web page on your browser if you prefer, and we'll share those links in the chat. Without further ado, welcome and thank you for being here, Dr. Irma Perez.
Well, thank you so much, and I'm really excited to get this opportunity to be able to speak with everyone about job stress, anxiety, and depression in mental health professionals and vicarious trauma. It was my choice to write a dissertation on vicarious trauma just because of the need and um, the job that mental health professionals do, the core job of a mental health professional. So we're going to talk a little bit about what vicarious trauma is, right? So vicarious trauma in mental health professional, it stems from that exposure to victims of trauma and that reoccurring and the reoccurring attending to the client's painful and what oftentimes can be very graphic accounts of abuse, torture, violence, amid other traumatic events that they've endured, right? And vicarious trauma is mainly marked by differences, um, individual differences, right? Cognitive changes in meanings and beliefs, schemas, and adaptations associated with a multitude of triggers that also result in those adverse effects, such as anxiety and depression. And just like I said, vicarious trauma, because everybody is so unique, it's going to be manifested very differently in individuals, and it's also going to be impacted by um, what's happening around them. Jobs, family life, personal life, school, other things that mental health professionals experience on a daily basis, aside from their work. So I think I chose this as like my dissertation because of that, because I wanted to normalize, like Miss Rodriguez was saying, normalize the fact that this is a physiological response that we feel based on our job responsibilities, our roles, and how we interact with our patients.
So, thank you so far for that introduction, Dr. Irma. As you all remember me mentioning, this is one of those interactive slides that I was talking about. This is going to be completed through Slido. You're welcome to take your phone out at this point and scan the QR code on the top left corner of the screen and answer the question, what is the first word that comes to mind when thinking of vicarious trauma? If you prefer, you can also use your web browser. You can go to slido.com and enter the code that you see on the bottom left-hand side of the screen, which is 1899010. And I can already see some responses coming through. I see stress, heaviness. Please continue to add your responses. Stress is a really big one. A lot of people are entering that in. That's why that word is getting bigger and bigger. Depending on your responses, the words will change in size. There's fear, toxic empathy, trauma, uneasiness, worry, numbness. Lots of great examples. I see suffering, anxiety. Fear is getting bigger, confused. Trauma is also getting bigger, overwhelm, fatigue, pain, clueless. There's also some responses in the chat as well, overthinking, fatigue, anxiety. Anxiety is getting a lot larger on the screen as well, and so is fear. Personal and work life overlap. I think that's an important one to remember. Overthinking is also getting bigger. Lots of great responses. You can continue to add your responses. We'll move on to the next slide and ask a follow-up question. Thank you all for your responses. So our next question is actually a poll, and it's, have you experienced vicarious trauma? We're already getting some responses coming in, but once again, you can scan the QR code with your phone, or you can go to slido.com, enter the code, and answer the question through there. There's a small number of no's, a large number of yes, and about half as many of the yeses are people who are unsure, which I think is a very fair response, considering that some people might not know what qualifies as vicarious trauma. What does that look like? And it becomes compounded by the fact that vicarious trauma can look differently depending on the individual and also the work that they're doing. So right now we have about 64% of people are saying yes, 32% are unsure, and 4% are saying no. And we also have a few people sounding off in the chat that they have experienced vicarious trauma. So I think we can continue on. Dr. Irma's gonna move forward with her content, but y'all can continue to respond and sound off in the chat as well. Thank you.
Okay. So my why. This is the reason that I chose to highlight vicarious trauma and its impacts on mental health professionals. Through my journey as a clinician, I started working with an organization where I held and had the opportunity to work in many positions. Right, this employment afforded me the opportunity to work with diverse populations, as far as undocumented children, as well as staff members, and come to understand the role that each one of us plays when we're working in a shelter setting and working in the through the reunification process. Um, so I'm just going to start a little bit about, talking about my role when working in an organization in a shelter setting. My first position was a clinician, right? And I I I experienced vicarious trauma. My son must have been about 11 years old when I first started with working with the organization. And I mean, working with this population, I want to say that 85 to 90% of the children that we work with have experienced some form of trauma. Just the journey in itself, is traumatic, aside from all the other hardships that they may have been experiencing in home country throughout the journey, exploitation, mistreatment, abuse. Right. And so to hear these stories every day and not come home with them was really challenging for me. I feel like I started becoming very paranoid with my son. He was 11, like I said, he's going to be 11, 12. And so just even wanting to go over to friend's house, like, who's there? Who's going to be there? And how long he could be anywhere. And then, he was like, why are you so hard on me? Why are you so worried? And then I started to question myself, like, what's happening? Well, as clinicians, we want to therapize ourselves. I don't know if that's even a word, right? But we want to like understand, okay, where these feelings come from. So I started to really look back at, why am I being so controlling of everything that he does and trying to worry about everything? Well, it was because I couldn't help but bring home everything that I was hearing on a daily basis. And at the time that I joined the shelter settings, we were in influx mode. So these numbers were so high, and our intakes were crazy. We were seeing 10 to 12 clients a day, and just experiencing the whole reason that they came, what happened through the journey, and writing what back in the days used to be called SIRs, that they became CLEs. They've changed throughout the process, but it was really um trying to get a hold of why I was feeling the way I was. And so I started looking into it more, and it was that secondary traumatic stress that I was experiencing that was causing my cognitions to change, my thought process to change, my beliefs, how I felt about my son, and just the world in general, that changes. So I experienced vicarious trauma, and it was difficult to acknowledge it and then to deal with it. So then as I grew in the organization, I became an assistant lead clinician. And so at that point, I knew that what clinicians in these types of settings were dealing with. So it was about now advocating for the clinical teams, advocating for the case management teams as well, because we work hand in hand, as well as the youth care workers and everybody that had a role with the undocumented minors. So I started to advocate for the service providers, recognizing mental health, recognizing the need for time off, recognizing the need to, sometimes step back from those complicated cases. I would have to sit with team members and say, okay, you've gotten really close to this case. I'm seeing how this is impacting you. So, you know what? Let's take a mental health day. I want you to take tomorrow, the rest of the day off, and just let's come back, let's regroup, we'll staff this again. And sometimes it even took, you know what, we're going to go ahead and change the clinician and give somebody else an opportunity because of the complexities of the case, right? So my role changed as far as advocating for service providers. Like I said, in every role, especially the youth care workers that were with these clients 8 hours a day, sometimes 10, depending on what the schedules were looking like, right? Then I had the opportunity of becoming a clinical director of services. So at this point, I become a clinical director overseeing 7 shelters. Well, not the shelters, but the clinical departments for all those shelters, right? So working with all the leads and the assistant leads, right, was the role that I took on next. And as we dealt with those complex cases for every shelter, I understood, and not right away, but recognize the need for self-care. Because without that, how were our team members going to be able to provide the adequate services for our the youth that we served if they were struggling themselves with getting it together and coming home from a long day of very, very traumatic experiences and having to deal with that, and then going home to deal with family life, being parents, and taking care of their own family. So I started to work with the team members and started to identify how we could advocate for self-care, how we could make sure that our team members were taking care of themselves, and also recognizing when they needed to take care of themselves. As I moved along through my journey with this organization, I also came back into the role of an assistant program director for one of the shelters, and that really afforded me the opportunity of bringing awareness of all the roles and responsibilities of the staff and the importance of mental health. So many of you that have already worked in shelter settings know that not all the time did our clinical directors or assistant program directors or even higher up organization members know what mental health was, or knew what it was to be providing these types of services to these youth that came with so much trauma themselves, right? So, I remember saying, like, you know what, I feel like this clinician, we had a very complex case, and just spending hours and hours of after work, putting this together, getting ready to staff it, getting ready to try and move this client to a place that would better that would provide the more appropriate services. And I remember saying to one of my directors, like, she needs a mental health day, and he's like, what are you talking about? And not understanding what it meant to really take a mental health day and take a day off. So at that point, I became the advocate as far as talking to the higher ups about, hey, this is what these people are dealing with on a daily basis. These are just some of the things that they're seeing. You have no idea what stories we hear behind the doors when we close that door and we take a child in for session, or when we're contacting the parents to find out what happened and why they took that journey. So I knew then, right then and there, that, vicarious trauma was something that so many clinicians in shelter settings and in all mental health settings were experiencing or had experienced, and really wanted to bring light to it. Um, so when I started the doctoral program, one of the first things they said during our residencies is like, start preparing now. Your end journey is going to be your dissertation, but you need to start preparing now. And at that point, I knew already. I knew that vicarious trauma was something that I was going to continue to look into, advocate for, and bring light to as well. So that leads to my dissertation. My dissertation was on job stress, anxiety, and depression in mental health professionals, an examination of experienced vicarious trauma and gender differences. It took me a year and a half to write, and over 115 clinical articles were reviewed for this, and many countless hours in the library at home, and just trying to grasp all of the information that was provided, and then understanding as well how much information was needed. So what impact does this vicarious trauma have on stress, right? Anxiety, and depression? Well, like I said earlier, it does really impact everybody independently differently, right? But one thing that is the common denominator is that it never negatively impacts the clinical effectiveness of our roles, our personal well-being, and our professional responsibilities. Like I said earlier, um, as I went through the journey of doing the research and on the topics that I chose, I did come to find there were so many inconsistent findings. There were so many risks associated with unaddressed vicarious trauma, and the roles and responsibilities that mental health providers provide. And then also trying to identify and access benefits for clinicians, just activities in the community was one of the really important things that I wanted to do, right? Like I said, through my journey, I experienced so many changes in roles and responsibilities, but I also got to learn more about those people fulfilling those roles and responsibilities, and knew that this was something that needed to be addressed, and continues to need to spotlight um, those impacts. Limited research exists on gender roles in the vicarious trauma among mental health professionals. Um, when I went in to study job stress, anxiety, and depression, each one of them, understanding the different definitions because it's defined differently, right? Um, what I did struggle with was finding the difference in gender roles. How those gender differences influenced our service providers, right? Again, understanding these impacts that are essential to our well-being, clinical effectiveness, and then as well as strengthening those community outcomes. My study was what the two independent variables that I wanted to study was vicarious trauma and gender. I wanted to see how vicarious trauma impacted mental health professionals, job stress, anxiety, and depression, but also how whether being a male or a female was, how would that differentiate, right? So those my two independent variables were gender and vicarious trauma, and then the three independent variables were job stress, anxiety, and depression. Overall, I sought 100 mental health professionals to complete my study, but after initiating it, um, The population ended up being as far as 100. Out of the 100 participants, 88 completed the full evaluation, which was um, obviously reading through that's what the study was about, and then completing those questionnaires. The background of the staff that I wanted and the personnel that I wanted was those with a bachelor's degree or higher that worked in the behavioral health field. I wanted to make sure that they had direct experience with clients, service or supervisory, either case management, social work, counseling, or any other therapeutic roles. Okay. And then what I had them do was fill out 4 self-report questionnaires. The first one was a general work stress scale, which assessed just generally how these mental health providers experienced work stress, um, and how often, how it impacted them, And then the next 3 questionnaires that I had were the Beck Anxiety Inventory, the Beck Depression Inventory, and the Trauma and Attachment Belief Scales. So the Beck Anxiety allowed them to give me some insight on any anxiety that they may have experienced. Depression, the Beck Depression as well, and the Trauma and Attachment Belief Scales. All of these were questionnaires that were anonymous, so they didn't have a name on it. It didn't have to worry about it. But I do remember that when I submitted this to the internal review board from the university, I did get a lot of requirements. I did get a lot of expectations because I was going to be working with a human population. And because this study and these experiences could be and very impactful to these clinicians. I don't know how, sometimes maybe looking at the Beck Anxiety Inventory and answering those questions, how that was going to impact maybe Joelle, it was going to be very different. And the university really wanted to make sure that I was taking every precaution to make sure that if these questionnaires were to bring up any kind of trauma for these mental health professionals, that we were going to be having something in place for them, right? Who they could contact, what kind of help would be out there for them, right? So that right then and there, also, I really appreciate that because that to me said, okay, they understand how these symptoms and these diagnoses and the work that mental health professionals do and how they're experiencing it, right? So I did have to do a lot of interventions and provide several options for those persons that did participate in the study, as far as providing them options. And then, okay, oh my goodness, I talk a lot, I'm sorry. So talk a little bit really quickly about job stress. So those professionals that experience job dissatisfaction, some of the symptoms that were found throughout the study were, that the developing of negative attitudes towards clients sometimes, or delivering lower quality or inconsistent care, really high turnover rates. So these are professionals that are experiencing this job dissatisfaction, right? And then so what results of that? Disrupted community continuity in the services. There's gaps in the delivery, and then those also the weekend supports for clients and mental health recovery. Less people available to help provides less resources for our community. And then anxiety and depression, right? So, what happens with unmanaged therapist anxiety? We're having countertransference, projection, emotional disengagement, demoralization, right? So, it was really important to understand what are some effective anxiety management tips, right? So, by incorporating these self-care and these interventions, we prevent inadequate service delivery. We preserve those therapeutic alliances, and then we also reduce the harmful outcomes for clients. Depression was another thing that was really interesting to find a lot about, right? To understand that depression counts for 10% of the global non-fatal disease burden was something interesting to me. Also, to understand that women and girls are disproportionately affected by depression was something that was very interesting to me, and really made me seek out those sources and want to understand it a little bit more, right? So I also found out that there was a significant gender gap in the diagnosis of depression, anxiety, and job stress in males and females, right? And even though there was that gender gap, I also found the importance of understanding that also anxiety, job stress, anxiety, and depression should not be overlooked in men, because it's not that it's not experienced, but what I did understand was that lack of reporting it. And a lot of that has to do with the gender roles.
Well, thank you so much for sharing your expertise with us, Dr. Perez. I think it's safe to say that a lot of us learned much from your dissertation so far. And we're going to continue to hear from Dr. Perez before the end of today's session. But before we do that, we are going to be watching a short video in which I share my personal experience with secondary traumatic stress and how I was able to identify the symptomatology myself. Although this is different from vicarious trauma, there's a significant overlap between vicarious trauma and secondary traumatic stress, burnout, PTSD, and compassion fatigue, as we saw in the Venn diagram that was presented earlier in the session. So as you watch this video, I would like you to notice some of the similarities and differences, but more importantly, take note of anything that resonates with you. And this video is part of the online learning module series on the 4 R's of trauma-informed care that was developed by RMTAC. If you're interested in learning more, you can find more information on this and other topics through our website under the Learning Hub. But for now, let's watch this portion of the video before moving on to our breakout sessions. Hey. I'm Esther Rodriguez. I'm a clinical consultant at RMTAC, and I'm going to talk to you a little bit about my experience with secondary traumatic stress when I was a home study and post-release services case manager. I'm going to start with some of the signs and symptoms that let me know that I was experiencing STS. The biggest one really was actually my somatic symptoms, which were my medical and physical symptoms. They were manifestations of my emotional distress. And it was a really hard time for me to maintain a healthy appetite. I was constantly feeling nauseous. I was throwing up a lot, and I ended up in the emergency room and urgent care several times. And I realized it was a symptom of STS when the medical professionals could not find a medical or physical cause for my symptoms. And then it became increasingly obvious too that I was experiencing compassion fatigue towards my clients. I was no longer responding to them with caring and empathy. I was more annoyed and frustrated, both with the system, but also just with the experiences that they were having. And I know that if I would have continued to ignore my symptoms, my compassion fatigue would have just gotten worse. And I would have experienced worsening burnout, where I was having a hard time staying motivated and completing work tasks and maintaining relationships with my clients, being supportive, and even completing things like progress notes and reports, just because I did not have the energy, I didn't have the capacity to stay focused on what I needed to do in order to support my clients. And if I would have continued to ignore the symptoms of STS, I know I would have also experienced a worsening or a deterioration in my work and personal relationships, because not having the energy And being so fatigued from the burnout, the compassion fatigue, and the STS, I just didn't have bandwidth left to be present for my relationships in and outside of work. So in a few moments, we're gonna start transitioning to our small group breakout sessions. As we discuss vicarious trauma, secondary traumatic stress, burnout, PTSD, and compassion fatigue, it is important for us to recognize that it can present differently in everyone. As you heard in the video where I shared, I did experience a lot of physical symptoms, but I also shared that I experienced fatigue and it impacted my relationships as well. So, as we combine all of our shared experiences, the hope is that we can be better equipped to not only support ourselves, but also each other as we're serving those in need. Perfect. Thank you all so much for your conversation and your discussion. At this time, we're going to take a few minutes to hear from each group. So each group will select their spokesperson and take time to share a recap of what was discussed during the breakout session. So we can go ahead and start with group one.
I will share on behalf of Group One. We were too deep into our discussion to assign. But yes, a lot of the participants in Group One were speaking about how they really resonated a lot with what both you, Esther, and Dr. Perez shared in terms of experiences with vicarious trauma. A lot shared about physical symptoms, somatic responses that they had, like loss of appetite, headache, stomach ache, exhaustion, restlessness, anxiety. And then one of the other main themes that popped up for our group was just that feeling of helplessness that can kind of continues to show up in the work that we do. And in terms of just like some work practices or organizational practices that impact symptoms of vicarious trauma. We talked about like limited resources, pushing productivity on clinicians, and then even just things like government shutdown. So not knowing where to like have clients turn to for support, things like that. Those were some of the things that came up in our group.
Thank you for that recap, Lisa. It sounds like your group had a lot of healthy discussion, especially around symptomatology and also organizational policies that may have impacted workplace stress. Thank you all for that discussion. So room two or group two was my group. And we also did not pick a spokesperson. I can recap some of what was discussed. But our group mentioned around experiencing secondary traumatic stress when listening to minors. They were working a lot with minors and their experiences either in the home country or during their migration journey to the US, and how and someone shared a specific instance where they were working with a child that had significant behavioral issues and found that they would stress pretty much any time that they were not at work available to support that child. And that looked like inability to sleep and complete other tasks at work. And we heard from clinicians and case managers alike who said that they even experienced shifts in what they found they could enjoy. They no longer enjoyed some of the shows that they used to watch because after hearing the experiences of the clients that they were working with, things like true crime shows were no longer as interesting or exciting for them because it was a bit too close to home for them. And then, of course, with all of the uncertainty and all of the changes that have been going on and trying to navigate as a provider or someone in the field, that it became even harder to be positive for clients when they didn't know, they were uncertain about changes and how that would impact them. And there was a group too of individuals that were working with the same organization that experienced a weather disaster, which impacted their ability to provide services, which is a whole nother thing that goes beyond even what we've been discussing so far, is some of these challenges that are outside of our control, beyond, organizational policies or relationships with clients, but also challenges outside of our control, outside of our agency's control, and how that changes the way that we relate. So it's a little bit of what we discussed. Let's move to room 3.
Few of us discussed about our different experience, and we had someone talk about working as in the CPS and experience someone working with the young children and immigrants children, provider, medical provider, and everything what was experienced, and how we each was in a different way we deal with anxiety, and how we deal with the different situations and what help us. We had someone saying that going home and hugging family, it helps to feel better. Someone had the problems with feel comes to the point where they had problems with sleeping, and wanted vacation but couldn't take vacation, and learned that end of the day just closing the computer, stepping away, that helped. I personally, for me, it helps me when I have someone to talk with, maybe coworker, maybe supervisor, and also it helps me to feel better when I help that individual to reach whatever that goal is in front of him or her.
Yeah, I know that was a great job, Sabina. Basically, it was like, basically it was this, experiencing the secondary trauma, the vicarious trauma, with regards to the awful situations that the clients and patients that we work with as professionals brought to us, and how we dealt with them. So yeah, Sabina did a good job in terms of relaying our discussion. So thank you very much.
Thank you all for sharing. Just in the interest of time, I'm going to go on to group 4.
Everyone has talked about a lot of the similarities of the symptoms. And so I thought maybe I would focus on the organizational practices. We talked about how there was kind of lip service to you should take care of yourself, that organizations had unrealistic expectations, and that sometimes the nature of the role that you're working in just has that vicarious trauma, or even basically first role trauma, that there's often limited staff and you find yourself working nearly 24/7 just to keep up with paperwork or follow up, and that there's disproportionate services for groups of people. Some positive things that Luce talked about was how she does some redirective self-talk when she recognizes some vicarious trauma happening or maybe going to happen in her headspace. And that kind of helped me understand that maybe it's a good idea to always have a different space than your therapeutic space, that you can walk away from. Maybe it's not a good idea to live in the space of the place where you do therapy with people who have experienced a lot of trauma. And then also compartmentalizing. If you're able to compartmentalize in your own thought processes, it might help you not internalize so much that trauma that one of your clients, students, patients has experienced. That's all.
Wonderful. Thank you all so much for sharing those insights. It's very clear to me that the discussions during the breakout session were fruitful. So now that we've all discussed in our group, we're going to consider this question. What unique challenges do refugee serving providers face compared to other behavioral health professionals? So this is another Slido. You can go ahead and scan the QR code on the screen with your phone, or again, you can use your browser and go to slido.com and just enter that code 1899010. You can provide an anonymous response. Again, the question is, what unique challenges do refugee serving providers face compared to other behavioral health professionals? Navigating so many different cultures, language barriers, discrimination, everything is unfamiliar. Totally fair. I think cultural nuances hitting close to home. Okay, now we're getting a lot. Increased trauma load. Whoa. Language barriers seems to be the one that's getting the most. But there's discrimination, trust or lack thereof, awareness, a lot more red tape, population, culturalism, trust and safety concerns, legal woes. The list goes on and on. And this question is helpful for us to remember that within each role, within each field, there are specific challenges that are faced, even in the same arena. So behavioral health professionals in general can experience a lot of what we've been discussing so far, but with refugee serving providers specifically, there are unique challenges, and this shows quite a few of what those are. So we're going to go ahead and move forward to give Dr. Irma Perez some time to present for us again. Thank you all again for your discussion and your interaction with the content so far. Let's welcome her back as she continues the presentation on the challenges that providers working with refugee and resettlement communities face, and then the gender implications that she discovered during her research.
Alrighty. Well, it was so good to hear all of the stories. The room that I was in did share about, their ability to not be, their inability to leave work. Financially, we can't just get up and leave our employment, right? So we really have to work around it and do our best. And somebody shared just, actually putting their computer away for the day. And it really resonated with me because I actually thought about that. I want to say that it may be a bit about 2 weeks ago, I left my computer at work, and I did not realize that it had been over 4 years since I had left my computer at work. I went back to when I was doctoral, writing my dissertation. Everything came home with me. I never stopped, never stopped, never stopped. And the other day I said, I had something to do, and I'm not even sure what, but I just remember coming home and saying, like, wow, it's been years since I left my laptop at home. And I was like, what do I do now? Like, what do I do now? I actually had time to like relax. My niece is in a book club, so she's like, you really need to join our book club. I'm like, girl, this is just one day. Let's move slowly. But recognizing, right, that we do need to really step away sometimes to give ourselves the opportunity to process everything that's going on and recognize our other roles and responsibilities that we have, as a mother, as a daughter, as a partner. All those responsibilities also tend to have that decline, or that we tend to negate when we are focused or dealing with these kinds of traumatic experiences. So my dissertation was on the job stress, anxiety, and depression that mental health providers experience, right? And assessing the gender differences and the experience of vicarious trauma. But what I'm going to talk a little bit about right now are some of the challenges that you all shared right now as far as serving the refugee and resettlement communities, right? There's occupational, personal, and environmental factors that also place our mental health providers at risk of developing these symptoms. So some of the occupational issues is that high caseload, which I think that was also shared in our group and shared by another group as well, is, the high caseload at work, depending on how many cases you're getting. I know that has changed with the times, but even now, whether it be a high caseload or a low caseload, what's going to happen, those, that uncertainty that was talked about earlier as well. Sometimes there's a lack of adequate supervisory support or training. Sometimes they expect that because you have a master's degree in education, guidance, or counseling, or because you've done this before, that should be enough, right? And not providing that support and saying like, hey, it's okay to ask for help. It's okay to feel like you may be overwhelmed. Let's talk about it and let's see how we can move forward together. When that's not there, of course, we're going to have those challenges. Those long hours and frequent exposure to distressing stories, human rights violations, PTSD, depression, anxiety, and related difficulties. When you work with shelters for immigrants coming from Central America, the hardships that they experience are very different from what we experience here in the US, right? Or what our children are experiencing. The type of violence and the type of poverty that's observed in those countries is way different than what we experience here. So taking all that in is definitely going to affect us in our occupation, right? And then again, going back to that workplace uncertainty, that lack of sustainable resources and the systematic support. Before, maybe the concern, like I said earlier, was about high caseloads. Now it's, what about the low caseloads? What about the closing of certain organizations, right? What about, is there going to continue to be employment for me? How am I going to provide for my family? All right. So those are some other occupational challenges. Personal challenges is that shared history, right? A lot of times you have that personal connection to trauma. I really tie that to my experience of experiencing vicarious trauma, because it happened to me and because of how it impacted myself and my family, my relationship with my son. I have that personal connection with that, and I really I don't know what the other word I was talking about last week. Very passionate. I'm very passionate about this topic and making sure that all of those mental health providers in whatever setting they should be at are recognizing the signs and symptoms and able to understand that there is help out there. The bicultural identities and community expectations. A lot of times we don't have the resources, right? So those expectations are not being met. The emotional burden of advocacy. Again, a lot of times when I was in the role of an assistant program director and talking with other directors or other organizational leadership that didn't have that mental health history background or that clinical background, getting them to understand what it was like a lot of times was daunting because it was downplayed. It was almost like as if um, I was making a big thing out of nothing. And I don't know how many times I got like, there's no such thing as a mental health day. I almost had to define it on occasion and really advocate for it. And then the lack of self-care and boundaries. I think it's important that we understand our boundaries and recognize, know ourselves, know our bodies, know when we have to say, okay, I can't take on this other case, or this case is taking too much of a toll on me, right? I have to set that boundary for myself, right? And then say, like, okay, now I need to leave my computer at home once a week. I'm going to leave my computer at home once a week if that's what you can do. Or in my group, the group that I was in, somebody said, just going home to hug your family, and just give them a hug and realize like why I go to work every day, right? To be that provider, right? So we have to take care of ourselves. And then there's the systemic challenges in the community, a lack of access or support to the debriefing processes, limited resources, even with the programs, not only the children that we worked with, but we end up working with the families because as we assist in that reunification process, but then at the same time, it was a lack of resources for the family once the reunification occurred. And having them or assisting them to reach out to the resources that are available was another thing that was really stressful, knowing, this child is going to go here and they have these so many needs. Are these caregivers really going to seek out the resources? And is there going to be the resources available for these children? And then, the government, the high levels of systematic stress, and then the government and the processes and the changes. There's no way to downplay everything that's occurring now at days and how the immigrants and this population, their family members are being impacted by the new government and the new regulations and expectations, and that in itself has caused so much stress again on providers, on all roles of on all the roles in shelter settings, as well as the family members and our patients. So these are just some of the challenges of serving those refugee and resettlement communities. And so again, some of the implications of that is some of the numbers and that were brought for our attention is like that 1 in 5 providers of those serving those refugees in the resettlement communities experience secondary traumatic stress, which again is under that umbrella of vicarious trauma, burnout, and all of the other secondary stressors. So also it's important to recognize that female providers are at greater risk for experiencing and sharing these hardships, right? So one of the things that I did find throughout my research was that the gender roles and the stereotypes, they really initiate powerful gender role expectations that influence how professional deals with stressors in the workplace, basic, common, and complex disparities and the anxieties of daily living. Women face the double dilemma of not only being a an employee, but a provider, of a wife, a mother, and a home, taking care of a home, as opposed to a male that comes home and brings his check, and by handing it over, basically he has met what society's gender role expectations are, and that in itself is very, very different, right? And the research indicates that 40% of American men and women in the workplace, they still endorse that customary gender role ideals. So we continue to feel these gender disparities. Also, that the gender differences, the divisions of roles, and the expectations they're perceived in various, if not all, levels of the work place, society. They're seen basically primarily in the gender gap pay, the organizational hierarchies, employment opportunities, occupational gender role expectations, cultural and societal assigned gender norms in the workplace. So we're seeing those gender differences. Aside from going home and having to care for a sick child, the female employee still has to come back and meet her quota, depending on whatever that expectation may be at work. And when that's not being met, that's that additional stressor that women are being exposed to. Females are more susceptible than males to experience anxiety and are generally diagnosed with most anxiety disorders, right? So again, through my research on my dissertation, I did find that females remain more likely to be diagnosed with anxiety, to include agoraphobia, panic disorder, separation anxiety, specific phobias, social anxiety disorder, generalized anxiety disorder, obsessive compulsive disorder, as well as acute and post-traumatic stress disorder. And a lot, again, going back to that is, again, the empathic role that females play, whether it be as a mental health provider or, in a clinic, working with victims of trauma as well. Though we're going to see that empathic stance that's taken on. And then also depression in women, right? They're believed to experience depression twice as much as men, right? So some of the social and cultural norms are that the gender differences associated with gender roles are the assigned expectations, like we talked about earlier, not only being the employee, but the provider, the caregiver, the wife, and making sure that the home is taken care of, right? So these are additional stressors that contribute to those elevated numbers, right? And then there's also the underreporting in men. Ambivalent numbers of men often suppress the symptoms because oftentimes admitting to depression conflicts with that expectation, right? Men are supposed to be strong, they're not supposed to express that they're feeling depression because it may be seen as a cultural stigma, right? That they're weak or they're not able to handle the stress of daily life. And so what we found was, and what I found even today, the numbers are that even though women are diagnosed 2 to 3 times more than males with depression, males are dying of suicide at twice the rate of females. So that right there shows some of the disparities in the underreporting and the acknowledgement of those symptoms of depression. And then thank you so much for the opportunity to come and share with you all, and I look forward to coming back again and sharing the results of the dissertation and sharing with you all the awesome findings that I had not even thought of when I started my journey through my dissertation.
Thank you so much to our subject matter expert, Dr. Irma Perez. All of your guidance and insight during the learning community is greatly appreciated. We are going to have to skip over our Q&A, but instead, what I would like to encourage you all to do is to submit a consultation and technical assistance request with RMTAC if you do have any questions that have come up as a result of the contents from this learning community. And the session summary, takeaways, and reflections will be sent to you all via email. We're going to take a few minutes as well. You can feel free to scan this QR code to let us know how we did and provide any feedback on the learning community. And as I mentioned earlier, this learning community is progressive. So our next session is going to be a continuation of our work today. It's on November 19th at 1:30 p.m. Central Time. And in preparation for that, we're going to ask you all to complete a workplace stress scale and a journal prompt that's going to inform the content that's going to be presented in session 2. Your individual results won't be shared, but it is going to tie into the material we will be covering. So we encourage you to complete that. And I also had a grounding practice to bring us all back into our present. So I just want everyone to take a few deep breaths, focus on what your body can feel presently, feel the floor beneath your feet, wiggle your toes, spend a few moments just noticing the sensations in your hands, the way your clothes feels on your body, taking those deep breaths. Because I know that this content can be really heavy and it can bring up a lot for all of us. So just make sure you give yourself some time after we break out to feel the calm in your body and take some deep breaths. On the next slide, we have that QR code again for you if you didn't have a chance to scan it earlier. And then just a reminder again, if you or your organization need any additional assistance, you can always feel free to reach out to RMTAC. We are here to help. You can submit a consultation and technical assistance request through our website. We typically respond anywhere between 1 to 3 business days. Our next slide shows you how easy it is to go to our website, rmtac.org, and click on that request a consultation or technical assistance button on the top right of the screen. It takes you to our form where you can complete your request. And then aside from this learning community, RMTAC has a lot of wonderful, robust information available to you. We have webinars that we host every month. Our next one is actually November 18th, and that's going to focus on grief and mental health among migrants and refugees, challenges in Hispanic and Latino communities. So if you're interested in that or our online learning modules, like I mentioned earlier, you can feel free to visit our website under that learning hub. And then lastly, if you have any questions and you'd like to reach out to us, you can also email us at rmtachelp@swkey.org. We encourage you to also visit our website where we have additional educational resources and recordings of our previous learning communities. So if you would like to share this learning community with members of your team, they can always watch the recording of part 1 and join us for part 2. And we also have an extensive services directory that's available to you all where we list some resources and referrals all over the country. And I do just want to take a moment to close out our session by just thanking all of our participants for your engagement throughout the session, thanking our subject matter expert, Dr. Irma Perez, for her insight and expertise on the topic. Thank you to our facilitators, Luz, Dr. Z, and Dr. Mutza for facilitating great discussions. And of course, thank you to RMTAC and our team, especially the producers, for all of your hard work making this a success. And just one final note for you all, we are going to talk about solutions to vicarious trauma in our next session. So definitely tune into that one as we recap and put an end note on everything we discussed today. Thank you all so much again for joining us, and we look forward to seeing you all at the next one.